Hello people, in this video we want to look at the top priority questions which will come from gynecology. So we will look at the questions and the answers. The first most high priority, post-menopausal bleed. Why is this so important to people? Because after menopause, if there is a bleeding, it can indicate carcinoma, endometrial carcinoma or cervical carcinoma. So you should always screen them for endometrial carcinoma and cervical carcinoma. So look at this. Any bleeding, okay, following menopause. First of all, what is menopause? Menopause is no bleeding for... Look at the definition of menopause. It is the permanent cessation of menstruation. It indicates the end of reproductive life due to loss of ovarian follicular activity. So it's the point of time when last and final menstruation occurs is menopause. So basically there should be 1 year of consecutive amenorrhea, okay, without any other physiology or pathology. Physiology means she's not pregnant or something. So basically consecutive 12 months of amenorrhea without any other pathology is called as menopause. Clinically, this is how you will diagnose. In these people, FSH level is going to be very high, remember. So if there is any post-menopausal bleeding, that is after she attains menopause, if there's bleeding, what are the causes? So here you can see here, endometrial hyperplasia, right? Senile endometritis, malignancy. So that's what we are very scared of, malignancy. Atrophic endometrium, dysfunctional uterine bleeding. It could be some ulcers, some IU, CD extra. Basically everything you will rule out, do a lot of investigations and find the cause and then treat it. Okay, that is what is postmenopausal bleed. Now let's move on to the next topic here, endometriosis. What is endometriosis, guys? You have seen our endometriosis video. So you can see here there is outside of the uterus, you can see a lot of blood, right? That is endometrial tissue or bleeding. That is endometriosis, okay? So in this, so where will you will find the functioning endometrium in sites other than the uterine mucosa. It's a benign condition, locally invasive. They are saying it's a benign condition. Cyclic hormones stimulate growth. All can it be? It can be in the ovaries, in the pouch of Douglas, fallopian tubes, all this you remember, okay? Ovaries, pouch of Douglas, fallopian tubes, ovaries, fallopian tubes, I think you will write easily. Everything else actually is covered, sigmoid colon, appendix, everything you can write, pelvic peritoneum. So there are some theories, why did all this endometrial tissue go there? So basically this is your uterus and here's your fallopian tube and ovary. So what happened, instead of the bleeding happening like this, there is some retrograde bleeding that is happening. That is one of the theory. What is one of the theory? Retrograde menstruation. Another theory is this coelomic metaplasia. What is coelomic metaplasia? The cells which are there here, okay, let us say there were some cells here, these itself transformed into the endometrial tissue, okay, so that is metaplasia, okay. So either the endometrial tissue went there or the cells which are there became endometrial tissue like, so that is metaplasia. So those are the two theories, okay. So this retrograde menstruation they're calling as Sampson's theory, and coelomic metaplasia they're calling as Mayer-Ivanov theory, okay. So if you want you can remember those names, but at least you understood the concept, okay. And that means some direct implantation. Direct implantation, it went there and it directly implanted there. So this can happen if there is some surgery that's happening and directly this tissue gets transplanted there. Looks like there are so many other tissue. By lymphatic it's going, by vascular route it's going, just like some cancer, you know, it's going everywhere. Main symptom dysmenorrhea, okay. Abnormal menstruation, infertility, dyspareunia, chronic pelvic pain, abdominal pain, write all this, okay. Do all the examinations necessary and then how will you treat? So there is some staging, superficial, is it superficial or is it deep, is it dense or what, is it dense or not, you should know, right, all this. So superficial or deep, dense or what is this, filmy. So all this you will decide, the adhesions and all, how bad it is. Once you do all that, go and treat, okay, how will you treat? Preventive. So this is very standard gynecology, what do you say, language. Get pregnant, have child, okay. Then curative, how do you cure it? Pain, for the pain you'll have to tell, okay. And then you try to improve the fertility, you prevent the recurrence. It's difficult to achieve, they are saying all this. So how will you actually do then? So you'll give some hormones, surgery also you can do. So for the pain, they are giving mefenamic acid. Pregnancy usually cures the condition, so you can either try to create a situation like the pregnancy or like a menopause also, so that she doesn't bleed. Okay. So pseudo pregnancy you can have. Focus here guys, this is very interesting. Endometriosis, you will create a pseudo pregnancy stage or a pseudo menopause stage, right? And you can give GnRH agonist to make it look like there is a medical oophorectomy, but actually there is no oophorectomy. Okay, so you're just trying to create a condition where it should not bleed. There should be no bleeding. Amenorrhea you're creating, okay? I think endometriosis video you go and watch, okay? Overall you understood, right? Bleeding will go out of uterus and then you make sure that the person doesn't bleed. So you either ask them to get pregnant or you give drugs which will create a pregnancy-like situation or a menopause-like situation or a medical oophorectomy. PID, what is PID? Pelvic inflammatory disease. 120, what's the page number? 126. This is a very generic thing only guys. PID, pelvic inflammatory disease. So basically infection. So imagine anybody has intercourse and the organism ascends and then it will affect the uterus, fallopian tubes, ovary, right? It will affect everything and then pelvic peritoneum and parametrium and then everything is inflamed, infected, inflamed. That is only pelvic inflammatory disease, okay? So basically, what and all is there in this? Inside this, you have endometritis, salpingitis, pelvic peritonitis, tubo-ovarian abscess, parametritis, everything. Cervicitis is not included in the list. That is very interesting. See where they started? They didn't start with cervix. They started with uterus. Okay. So which are the organisms? Gonorrhea, chlamydia, all these STDs. Okay. Then secondary organisms will come and join these people later. These people will first come and invade and then everybody else will come and create a nice bacteria hub there. Looks like it can be streptococcus, staphylococcus, bacteroids, even anaerobic. Okay. See, vagina is infected, that is vaginosis, etc. That is not there here. Cervicitis, vaginosis is not there here. Here they are talking little up only. Pelvic inflammatory disease they are talking about. Okay. Uterus and upwards. So what will be the clinical features? Pain, 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 pain. Very good. Fever. Excellent. It's an infection. They can have some irregular bleeding. Very good. Discharge. Yes, they can have. Very good. Nausea, vomiting, dyspareunia. Yes, that is difficult intercourse. Then they have some pain in the right hypochondrium due to concomitant perihepatitis. This is Fitzhugh-Curtis syndrome. Can you remember this? Where's your right hypochondrium, by the way? Hypochondrium. Chondrium means what? Somewhere near your liver, people. That is what really right hypochondrium. Okay. Now let's get back to the textbook. We are looking at PID, right? Good. So look at the criteria here. If they have some histopathological evidence, then definitely it's a definite criteria. If imaging also shows that there is some thickened fluid-filled tubes, tubo-ovarian complex, etc., then it is a definitive. Okay. Minimal criteria means abdominal tenderness, etc. Tenderness, they are saying is minimum criteria. Additional criteria can be fever, discharge and all this secretions and laboratory documentation of infection with gonorrhea or chlamydia trachomatis. So what are the differentials? Very important. So it can be appendicitis, very important, a disturbed ectopic pregnancy. So please do not forget all these. She may come in pain means you should not think only pelvic inflammatory disease. What if it is an appendicitis? What if it is an ectopic? All these are kind of what am I saying? Emergencies. Then torsion of the ovarian pedicles. So that is very important. Endometriosis, diverticulitis, urinary tract infection. Okay, urinary tract infection. I think you will guess. What do you say? So outpatient treatment, ceftriaxone, doxycycline, metronidazole to cover the anaerobic looks like. Okay, this is outpatient. Ceftriaxone, doxycycline, metronidazole. Very important. Hope you are focusing. Then if these symptoms are there, you will hospitalize. Okay. If there is a tubo-ovarian abscess is there, if there is vomiting, severe illness, temperature is really high, then if there is uncertain diagnosis, you really don't know what problem is there, like appendicitis, admit her, just see if it's a surgical emergency. Okay, then if she's not at all responding to the outpatient therapy, if she's intolerant to oral antibiotics, then give her IV antibiotics or you will hospitalize. So if there's a coexisting pregnancy with this infection or inflammation, please admit her, right, if she's pregnant. And if she's a known case of HIV infection because why? She could be immunocompromised? Not yet, right? She's not an AIDS patient. Anyways, they have said hospitalize them. Now, inpatient, what will you give? You will give cefoxitin, doxycycline, clindamycin, gentamicin, ampicillin, doxycycline. Let's not remember the alternate. Remember regimen A, regimen B. Cefoxitin, cefoxitin, doxycycline, clindamycin, gentamicin. If you can remember the dose, very nice. Otherwise, at least remember the names. Doxycycline is similar to the outpatient, right? Only that is similar to outpatient. That much is enough about PID, guys. Then we will move on, okay, now. So, how's it going, people? Progressing very well. Now, let us go to the next question here. AUB, DUB. What is AUB? Abnormal uterine bleeding and dysfunctional uterine bleeding. Abnormal uterine bleeding. So, basically, anything apart from normal menstruation is abnormal uterine bleeding, okay? So, normal menstruation means 21 days to 35 days cycle. Okay, that is 28 plus or minus 7 days. If the cycle is long, then oligomenorrhea. If the cycle is short, polymenorrhea. If the bleeding days are fewer, hypomenorrhea. If the bleeding days are more, menorrhagia. If the total blood loss is less, hypomenorrhea. If the total bleeding is greater than 80 ml, menorrhagia. If there is polymenorrhea with menorrhagia, then you call it as polymenorrhagia. Very good. Then, if you have intermenstrual bleeding, metorrhagia. So many terms, wow. And then you have menometorrhagia. She bleeds anytime, not only intermenstrual, whenever, okay. Then, why does she bleed abnormal? Because of pump coin, you remember, okay. This is another way of putting it. Let's go to pump coin directly. Polyp, adenomyosis, leiomyoma, malignancy, PALM over. Then COEIN, that is coagulopathy, ovulatory dysfunction, endometrial cause, iatrogenic and not yet defined. Can you remember this? If this they will ask you in almost every exam. Pump coin, okay, remember this. Then, what is DUB? Dysfunctional uterine bleed. That is a state of abnormal uterine bleeding without you cannot detect any clinical cause for this abnormal. That means it is physiological. That is, she is either in menarche stage or in perimenopausal stage where they will have abnormal bleeding anyways. So if she comes with you any at that age is for some abnormal bleed. So it is dysfunctional uterine bleed. So that's what we are saying. Then there is one very important term here called as metropathia hemorrhagica. So this is after 40 years, okay, that is again perimenopausal. So this is called as cystic glandular hyperplasia. That is Oshoider's disease. The endometrium will become hyperplastic. And in this she'll have anovulatory cycle, so there will be no pain. This is very, very similar to PCOS in terms of clinical features. So this is how the endometrium is, see, endometrial hyperplasia. And this Swiss cheese kind of microscopic structure, okay. So always we tell you, right, in this menopausal age, you have to rule out malignancy, okay. AUB, DUB, they have sort of combined the treatment. Anyways, look at this. You can, for pain, they are giving mefenamic acid, then tranexamic acid. Basically, tranexamic acid is it will clot the blood, okay. So tranexamic acid is more like a short-term solution. Then you have hormones like norethistérone acetate, medroxyprogesterone acetate, progestin. So just remember this. You can give combined oral contraceptive pills, danazole, mifepristone, that is RU486, GnRH analogs, desmopressin. Okay, this much you can remember. Surgical treatment, you're talking about laser, roller ball, here, thermal balloon, microwave, etc. Okay, resection, so many things. Uterine artery embolization, then hysterectomy. So this is what they're talking about. So basically, you'll have to treat the cause also. That you should remember. Any anemia, you'll have to correct. You'll have to tell her to take some rest also. Okay. So in this ovulation dysfunction, no, it can be anovulation or what is that? Some ovulation words were there. Oligo-ovulation, polycystic ovarian disease. Then coming to endometrial. Endometrial means what? You can say endometritis, right? And when it comes to iatrogenic, because of use of IUCDs, etc. Or breakthrough bleeding because of oral contraceptive pills. Okay, all that is iatrogenic. Now we are done with AUB, DUB. Now what should we look at, people? Are you happy that you finished AUB, DUB? Okay. Now shall we go to PCOS? Okay. PCOS is this one. So polycystic ovarian syndrome. So basically in this people you can see that how the ovaries, polycysts are there in this. These are actually follicular cysts, and these people will have a thick stroma. You can see here. And what is the, how do you say they have polycystic ovarian syndrome? They will have anovulation, or that is oligomenorrhea they can have, or amenorrhea, hirsutism, hyperandrogenism, that is hair hair and all will be there more, right? Hirsutism. Then multiple small follicular cysts in the ovary. At least 2 of these, if it is there, it is PCOS, okay? So these people will have, they can have hair and, that is AN means acanthosis nigricans, insulin resistance, hyperandrogenism, insulin resistance and acanthosis nigricans. Here in the red circle they have marked acanthosis nigricans, okay? So people who have insulin resistance, a lot of people in the neck like this, you can see acanthosis nigricans, something to do with the epidermis, right? In dermatology you will know. So these people have something called as metabolic syndrome, that is they are obese, the triglycerides are more, the cholesterol, etc. The blood pressure is elevated, glucose can be elevated, that is diabetes, right? So basically in these people you can see here in normal you have this LS surge, in PCOS cycle you don't have LS surge. So what will happen, this follicle will not rupture and it will not release the oocyte. See here in the normal one it is releasing the oocyte at the LS surge, but here there is no release of the oocyte. So this follicle just continues to be like this only. Okay, so it will become follicular cyst. So this is what is PCOS. So basically, why does it happen? Because of obesity. Obesity what will lead to insulin resistance. Insulin resistance means more insulin. So insulin-like growth factor is more. If insulin-like growth factor is more, what will happen? The ovary will produce more androgens, and because of more androgens, what will happen? LH will be more, but there's no LH surge, and hence without LH surge you cannot have ovulation. So she will become anovulatory. So she will become infertile. Okay. Then can I say the word infertile? Okay. Then cause 2 is something to do with pituitary hypothalamus. So it is basically a higher level issue where the body itself is producing more LH and there is no LH surge. Okay, so that is the other thing. So what will happen when there is no LH surge? This much you understood. There is no ovulation. Okay. So when there is no ovulation, what will happen? There is this ovary will go on producing androgens, and these androgens will go on becoming estrogen. There is more estrogen. It's a whole vicious cycle. So much estrogen they will have. Okay. So this is that vicious cycle which we have tried to explain in that video. So here you can see that, shall we put it here? Okay. So see here, from the pituitary etc. more LH is coming because more estrogen is there. That is why more LH it is making, but there is no LH surge, and FSH is less. Because FSH is less, follicle stimulating hormone is less. So there is no, these follicles are not going to be stimulated. Wait, don't get angry. So because of this FSH being less, the follicles will not mature, etc. Without LH surge, these won't rupture and release the oocyte. So a lot of androgens. So it will lead to hirsutism. This androgens will get converted to estrogen, and it will lead to more estrogen. Estrogen will lead to more LH. There's no LH surge. So this is the vicious cycle. Okay. So this is what you should understand. So how will you treat this cause? The drugs are directly written here. So basically you want to what? You can directly give FSH because FSH is less. Now you have to give something that will stop this so much of estrogen. So you can give clomiphene citrate, okay? So look at this, clomiphene citrate you can give, and then you can give the conversion from androgen to estrogen should stop. So you can give letrozole. Letrozole will stop this conversion, aromatase inhibitor, right? So it will prevent the aromatization of this androgen into estrogen. So you can give letrozole. You can just go and destroy this ovarian stroma. Okay, just go and destroy all this so that it doesn't make any more androgens. That is another treatment. Right. Then you can give anti-androgens like spironolactone, finasteride, etc. That's yet another treatment. Then tell the person to lose weight if they are obese only. If they are obese, so that then this insulin resistance will come down. If insulin resistance will come down, insulin can be uptaken. So insulin will not become more, and insulin-like growth factor will not become more, and hence the ovaries will not go on producing androgens. Okay. People, this is revision video, so we are going fast, right? Okay. But you understood, right? Estrogen is so high. So because estrogen is so high, the pituitary is releasing lot of LH and very little of FSH, and this LH is more, but there's no LH surge. Because there is no LH surge, these follicles will not rupture. So there are so many follicles here, and this stroma of the ovary goes on making androgens, which goes on converting to estrogen, and the cycle is like a vicious cycle. So this is the vicious cycle of PCOS. So if you just, if she doesn't wish to make family and all, you can just give her progesterone so that her cycles will get regulated. Okay. I think if you understood PCOS, no, the entire gynecology you will understand, because PCOS, it explains the entire picture, you know, of the pituitary, the hypothalamus, the ovaries, everything. Now let's come back here. We are done with PCOS. Next we'll look at vaginal infection. Okay, people. So now let us look at vaginal infection. So vaginal infection can be fungal, bacterial, or because of protozoa, that is Trichomonas vaginalis. So basically fungal means candidiasis, etc. So you will have to, there will be curdy white discharge, right? So basically fungal means you will treat it with fluconazole, etc. Bacterial, chlamydia trachomatis, right? So bacterial, remember that you will give azithromycin, and Trichomonas vaginalis is because of protozoa. So here you can give, what will you give here? Ornidazole, right? Here there's one term called as bacterial vaginosis, guys. This is actually protozoa and bacteria kind of a thing. Gardnerella vaginalis with bacteroid species, Peptococcus, Mycoplasma hominis, etc. So this is a mixture of all this bacteria and protozoa looks like, okay? So fishy smell, creamy vaginal discharge with fishy smell, okay? Foul odor, remember, malodorous. So these are the clue cells. So when you do that whiff test, right? So just go down here. So you have AMSEL's 4 diagnostic criteria here. So you will have vaginal discharge, pH is more, okay, that means pH is more means what? It is alkaline, is it? Little more alkaline. A whiff test, positive whiff test, the presence of clue cells, okay. Whiff test means what? You will take a drop of the discharge and you will put this potassium hydroxide, that time you will get a fishy odor. So then this discharge also, when you prepare on the slide and you will see clear cells, sorry, clue cells. So this is what is AMSEL's 4 diagnostic criteria for this bacterial vaginosis, okay. So these are stippled epithelial cells which are called as clue cells. So you will treat it with metronidazole and clindamycin, you can remember. Okay, people, remember this much. Looks like there is a lot of virus also which causes all this infection, okay. So write about virus also, like herpes, HIV, etc. That will mostly come under HIV, STD, okay. Cervical cancer, let's talk about cervical cancer now. Cervical cancer is caused by HPV, human papilloma virus 6, 11, 16, 18. So basically you can see here, this is the outside world. From outside world HPV is coming and then it is causing problem in this cervical cells. So then there is a lot of changes that is happening here. This is cervical intraepithelial neoplasia, correct? Then the CIN becomes, after some time, it will become carcinoma, okay? So as of now you can see here, months to years it's taking, and there is till here it still has not invaded. Once it crosses this basement membrane, once it crosses this barrier and it is entering the body, right, and other organs, it is invasive carcinoma in which you have stages 1, 2, 3, 4, okay. So basically understand that here you have low grade SIL and then you have high grade SIL. This is Bethesda classification. So low grade SIL and high grade SIL, okay. So SIL is squamous intraepithelial neoplasia, is it? Lesion. Squamous intraepithelial lesion, okay. So did you understand, people? So did it become too much? So the human papilloma virus 6, 11, 16, 18 coming, and all the cells are changing, some chylomatosis, etc. is happening, and then it is becoming low grade is becoming high grade. After that it is invading, invasive carcinoma is becoming, in that you have stage 1, 2, 3, 4 based on how far it has gone, how down it has gone to the vagina and how far it has gone almost towards the ureter. That will become stage 4 kind of thing, okay. So in this there is one concept called as a transformation zone, okay, where there is all this problem will occur. See, there is an old squamocolumnar junction and then this keeps coming out, right, and this old squamocolumnar junction, and then there is a new squamocolumnar junction, okay. So between these two what you have is the transformation zone. So this is where they are expecting all this cancer cells to come, okay. So this is transformation zone. So whenever they are trying to visualize or do some biopsy, etc., they are targeting this area. So transformation zone is between the old squamocolumnar junction and the new squamocolumnar junction. So basically you can use for treatment of this, you can CIN, that is not, it's not yet invasive carcinoma. For that you can do some cryotherapy, cold coagulation, etc. Some biopsy also they are talking about, right? Cone excision, etc. So you can do all this, okay. Remember about Papsmear, okay. Papsmear will tell you about all this, how, whether it is CIN or what grade, everything it will tell you. Then only you are coming to treatment. If it is carcinoma, then you will treat it. You can do trachelectomy if they want family, etc., etc. Otherwise, you can do radical hysterectomy, pelvic extenteration, depending on how bad the situation is. Radiotherapy, brachytherapy, etc. Yeah, people, you finish cervical cancer. Cervical cancer is one of the most important topic, okay. Now let us go to fibroid, leiomyoma. What is leiomyoma? It is nothing but Problem of smooth muscle. So tumor of smooth muscle is called as leiomyoma. So remember, if it is the smooth muscle of the uterus, then only it is called as fibroid uterus. Okay. So leiomyoma can be there in many places, not just uterus. Leiomyoma is a common term. It can be uterus, urinary bladder, so many other places. But if it is in the uterus, then it is called as fibroid uterus or fibroid. So if it is just below the mucus, it is called as submucous. If it is below the mucus, submucosa. If it is below the serous, it is subserosal. If it is between these two, it is intramural, which is most common, intramural. Okay. Then what will you do for all this? The second cause, abdominal uterine bleeding. Remember, mass per abdomen also. So basically, the person whom you have to blame is estrogen. Okay. Whom will you blame for leiomyoma? Estrogen. Estrogen is the culprit. Okay. So basically, when will estrogen be always more? See, that means you never got pregnant. That means you did not give progesterone break for the body. That means estrogen. That means you never got pregnant. Okay. Nulliparity can be a cause. So this leiomyoma very rarely can become leiomyosarcoma. So basically, these people will have lot of bleeding because there is increased surface area of the endometrium because of congestion, dilatation of the venous plexus, because prostanoids, ulceration, tone vessels. So because of all this, they can have a lot of dysmenorrhea and menorrhagia. Okay, remember. So what will happen to this fibroid? You saw it can become sarcomatous. That only you remember mainly. Then it will undergo a lot of degeneration called as hyaline degeneration, cystic degeneration, fatty degeneration, calcific degeneration, red degeneration, necrosis, etc. These are the degenerations you should tell. Okay, that's the fate of the fibroid. Then let us look at the treatment. So basically, they are giving if the person wants family, or it is a small size leiomyoma, then they are just talking about medical management, and they will do myomectomy. They will just remove only that myoma. Yeah, myomectomy. Otherwise, if the person has completed family, then you can do hysterectomy. Okay. So basically, which are the drugs that are used to minimize blood loss? You can give mifepristone combined oral contraceptive pills, then prostaglandin synthetase inhibitors. That's only mefenamic acid, right? So danazol, standard treatment that you will give for abdominal uterine bleeding. Okay. How's it going, people? Now let us move on to prolapse, uterine prolapse. Okay. So basically, in this only FOTHERGILL operation will come. So we look off at both of these. Okay. How's it going, people? Are you feeling stressed? No? Going good? Okay. So let's start off with prolapse. Okay. See, prolapse, so you should know the stages. Normal means there's no prolapse. So external loss is lying at the level of ischial spine. There's no descent. Okay. There is something called a stage and degree. Okay. But everything is 0, 1, 2, 3, 4 only. So just look at this. Here they are saying stage, and this one they are saying that basically you can see here, if this is the vaginal opening, introitus, and this is the external os, is it? External os. See, this is external os. So external os has descended here, but it is still within the introitus, and then it is external os is at the level of introitus, then the external os has come out, right? And this is stage 4, complete eversion of vagina also. So basically, this is the pelvic organ prolapse, quantitative scoring. Then there is clinical degree. Clinical degree is same only almost. There you will call it as normal. Then you have the first degree, second degree, and then third degree. Third degree and this procedentia you cannot distinguish, okay, unless you palpate. So this is third degree, you can see, and then you have procedentia, okay. So procedentia means what? Involves the prolapse of the uterus with eversion of entire vagina. So if you want to distinguish whether, you'll see everything out, but if you want to find out whether the fundus you can feel, then you have to palpate, okay, then only you'll know if it's procedentia, okay. Usually will occur in older women, you can see. See, this is not same as what happens during childbirth, okay. During childbirth, the uterus can get inverted, right? Inversion of uterus, that is not what they are talking about, okay. Yeah, it is very similar though. But here the cause is not childbirth or anything. This is uterine prolapse. So here you, what are the fixes you will do? You will do for vaginal wall, you will do colporrhaphy, then perineorrhaphy, then you will do vaginal hysterectomy if required. Then following vaginal hysterectomy, they are talking about some repair vault. There can be vault prolapse, then they are doing repair of the vault. Okay, all this you should know. So basically you should know they will do colporrhaphy, perineorrhaphy, hysterectomy, etc. Now, when will they do this FOTHERGILL operation? When the cervix is elongated, they will do FOTHERGILL operation. They will ampute the cervix and then they will do some stitch. So basically, they'll ampute the cervix and then they are doing some FOTHERGILL or Manchester operation where they are giving some strummed off suture. Okay, you have to remember this. The posterior vaginal mucosa, they are suturing using strummed off suture, and the anterior, they are using the FOTHERGILL stitch. Okay, so they are taking this mechan rod and they are making it more strong. So they are taking the cut end of mechan rod and they are putting it in front of the cervix. That is FOTHERGILL stitch. Okay, so the front there will be FOTHERGILL stitch, posterior vaginal mucosa, strummed off suture. Okay, basically remember this. Okay, FOTHERGILL, when you are doing, whenever the cervix is too long, they are cutting the cervix and then cervix is exposed. No, so they will cover it with anterior vaginal, the vaginal wall mucosa. So the stitches are called as FOTHERGILL and strummed off suture. Okay, the surgery itself is called as FOTHERGILL Manchester operation, right? Yeah, FOTHERGILLs or Manchester operation. We have separate videos about this also, so watch that if you want to know in more detail. Okay, this is more like a revision high level video. Bye bye. As the remaining part, no, this much we will take in the next video, and also in the next video we will cover this specific terms in gynecology also we'll cover in next video.